Thank you, Chairman. Good afternoon. I'm Sae Hoon Kim from Korea. Today, I'm pleased to talk about the management of rotator cuff repair in severe osteoporosis and introduce several techniques to cope with intraoperative ankle pull-out. I'm sure you have experienced stress when faced with this devastating complication in weak bone. Osteoporosis is known to have a detrimental effect on tendon healing. Furthermore, as anchors are commonly used in surgical procedures, the risk of ankle pull-out becomes a significant concern. It is crucial for surgeons to be aware of these challenges and implement appropriate strategies to effectively address these issues. Why do we encounter weak bone in rotator cuff repair? General osteoporosis is one of the reasons, since rotator cuff repair is usually performed on the elderly. However, focal anchor site osteopenia is a problem specific to rotator cuff tears. During the procedure, we decorticate or perform microfracture, which decreases anchor stability too. Another important factor to consider is that preoperative stiffness leads to osteopenia at the humerus, which hampers secure anchor fixation. Since assessing generalized bone mineral density cannot accurately represent the BMD specifically at the humerus, which is the anchor insertion site, quantitative CT scan can be utilized to evaluate the quality of the greater tuberosity. A cadaveric study using high-resolution QCT revealed a lower density in the lateral lobe of the GT compared to the medial lobe, which is a quite well-known fact. There are numerous other studies that suggest a correlation between rotator cuff tears and focal osteoporotic change in the greater tuberosity area. This finding emphasized the importance of exercising caution when inserting anchors during the procedures. So what are the strategies? First and foremost, having a well-planned blueprint is crucial. Increasing the number of fixation points can be beneficial for loaded rows sharing, particularly in case of large tears or poor bone quality. Additionally, considering use of larger anchors or opting for metal anchors can prove to be effective strategies. During the anchor insertion, it is important to aim for an angle that is close to parallel to the line of pull, which corresponds to direction of the rotator cuff. The traditional Deadman's angle that has been commonly used in the past has been proven to have inferior pull-out strength when compared to a 90-degree angle. Therefore, it is advisable to avoid the Deadman's angle and strive for 90-degree angle during anchor insertion. A traditional transosseous repair could be considered in weak bone. Conversion to open surgery may help with the osteoporotic bone. Now, if you encounter anchor pull-out in operating field, what would be your next step? Traditionally, anchor pull-out rates after rotator cuff repair using metal anchors have been reported to be 2.4, 3.1, and 0.1%. However, in my study, screw-in type anchors showed a pull-out rate of 3.3, while soft anchors demonstrated a rate of 5.4. Several methods have been proposed to address these issues. Dr. Burkhardt introduced a technique called body screwing, which has shown a promising result. This technique involves the dual anchoring using screws that interfere with each other. Some studies have reported an increased row sharing capacity with this approach, while others have expressed concern about weaker fixation when there is a less than 4 millimeter of thread overlap. However, it is important to note that this technique should be employed before the anchor completely pulls out. Once a complete pull-out occurs, it becomes challenging to properly place the anchor at the insertion site. Another method proposed by Dr. Burkhardt involves adding an additional screw for rescue. This technique differs from the suture bridge approach, as its objective is to distribute the load instead of compressing the footprint. However, caution is advised when using a rescue screw, as it may result in a lower healing rate due to the micromotion caused by windscreen wiper effect and bungee cord effect. Cement augmentation showed a promise in enhancing anchor stability. Several cadaveric studies have demonstrated increased strength when utilizing cement in conjunction with anchors. However, there are several considerations to keep in mind regarding cement augmentation. Firstly, it can be challenging to predict which patients are at a higher risk of anchor failure. Additionally, there is a potential danger of cement leakage. Technically, manipulating cement in a watery environment can be difficult. Moreover, cement augmentation may decrease bone marrow blood flow and block the drainage of stem cells, ultimately resulting in a significantly reduced area of tendon healing. I would like to introduce a new and simple approach called BASP, which stands for bar anchoring using threaded aspin. This technique involves using a threaded aspin, diameter about 2.3 millimeter, that is cut to a length of 25 to 30 millimeter. The central 2/5 of the pin are wrapped with 3 strands of sutures. The pin is then inserted into designated hole with the shorter side positioned for ease of flipping. To facilitate the insertion process, we have also developed the impactor specifically designed to guide the pin through the bony cortex of the hole. With the aid of the impactor, the pin is carefully guided beneath the cortex. Subsequently, the strand of sutures are gently pulled, causing the aspin to flip inside the cancellous bone. This flipping motion ensures a secure fixation of aspin within the bone, providing a stable anchor for planned tendon repair using the 3 strands of sutures. During my comparative analysis of different techniques for addressing anchor pull-out, I examined the 16 cases of body screwing and anchoring at the different locations, 17 cases, and implement the BASP technique in 13 cases. Notably, failures are observed in body screwing and anchoring at different location technique. However, the BASP technique demonstrated a noteworthy outcome with no failure recorded. Allow me to present a demonstration after experiencing a disheartening pullout. We proceed to insert the BASP like this through the original hole, and with a gentle pull, you can flip the aspin in the cancellous bone. So it's quite stable. Post-op X-rays in several cases have revealed that the BASP is positioned horizontally against the cortex. In summary, it is crucial to be mindful of the focal osteoporosis in case of rotator cuff tears. especially when preoperative stiffness is observed. Ankle pullout present challenging problems, and traditional techniques have shown limited success in addressing these issues. However, the new method of bar anchoring using the S-pin can be a valuable asset for surgeons, offering a potential solution and improved outcomes in managing anchor stability and fixation. Thank you very much for your kind attention. Thank you.